so bear with us while we sync up. All right, and it looks like we are now live. So welcome everybody to our next session. This session is dedicated to specialties, modalities, and knowing what is right for you. We'll talk about how to become that subject matter expert, how to apply that to your chosen modality, and really everything in between. But, I'm joined with my good friend, Dr. Laura Goldberg. She is currently practicing in Maryland. Welcome, Laura. It's great to have you. You did your residency in primary care and oct disease, I believe.
Yes.
You also have a master's in vision science.
Yep.
You're doing specialty. You're doing myopia control, right?
Myopia control and scleral lenses.
That's right. I thought specialty contacts as well. Yes. Yeah. So you're doing a variety of things. So we've done a lot of talks together at Vision Expo, in person. So this is our first kind of webinar sort of talk. So it has a different feel to it, but it's good to see you again, of course. And, thanks for taking your time to hop on and, talk a little bit about this stuff. Before we jump into it, I have another secret code for those who have been collecting them and entering them into the raffle. You can enter the raffles by checking into the exhibitor booths through the exhibit hall. So hop in the booths, check in, and you can enter these codes. I've been leaving Easter eggs really in every talk. So the one for this talk is sublease. So you can enter sublease into your code. It'll enter you into the raffle, kind of give you additional entry. So without further ado, I guess we can jump right into it here, Laura. And, you gave us a little bit of your background. I gave everybody a little bit of your background, but, what are some of the specialties in optometry? There's a lot of them, obviously. And, we don't have to really list them all off because there are so many, but, when did you really think about specialties and how did you kind of come about choosing one for yourself?
Well, I think it kind of just almost fell into my lap after I did my master's. It was actually involved in kind of myopia research with atropine, which is one of the treatments for it. And I didn't realize how big it was going to be when I pretty much beginning a residency, kind of after I finished, it kind of took off. And a lot of the big studies were released to the public. And then I kind of thought, well, I have this background in it. It might be a really good opportunity for me to be able to kind of apply that to my clinical settings. So I did kind of some lead work on the new research that came out, talked to some mentors that I had growing up who had been doing it for a while. And then I kind of just slowly jumped in and started kind of offering it to my patients. And it kind of just grew from there.
I mean, do you think you kind of choose your career path and then pick your specialty, or do you think you pick your specialty and then choose your career path? Is it one or the other? What comes first?
I don't know, because I think you can change. Because I started off thinking that I want to do oct disease, and I'm glad that I did it because it gave me a really good foundation. But then you kind of meet other people, or you kind of get new opportunities coming your way. I just had a few patients who had keratoconus and they had no one else to go to. So I thought I'd try it out. And, I've worn contacts my whole life. So I've always been interested in contacts. And so I kind of just, taught myself. And I did get some advice from others on how to fit. But really, I just kind of went into it myself without any formal residency. And, over time, I really became quite successful with it.
Yeah, it's interesting you mentioned that because I feel like if you do a residency in something, obviously it's easier to kind of call yourself a specialist or feel like a specialist, feel like you have the confidence to do it more because, you've done a residency and you've been immersed in it. But, a lot of people do specialty services or offer specialty services that, you didn't do a residency in specialty contact lenses, but now, you offer that and you're confident and you're comfortable doing it. How do you build that confidence, for those that either did not do a residency or have no plans on doing a residency, but want to be a specialist in something? What are some of the steps that they can take to really become that sort of expert, so to speak?
Well, for example, with the scleral lenses, I basically picked a lens that I thought would be universal and worked really well for most patients. And then they have really great consultants on the phone. So they understand that if you're a new fitter, they'll usually walk you through it. So they'll go over all the steps on like getting the trial lenses, what to start with. I actually used one of the new grad optometry articles, like Beginner's Guide to Scleral Fit. I still reference that.
It's a great article. Yeah, that thing, I think it's got over like 30, it's got like somewhere between 30 and 60,000 page views. I'm pretty
Yeah.
sure it's a very popular article. Yeah, check it out if you're interested. But
Yeah, it's
sorry,
great. No,
shameless
it's
plug
true
there.
though.
Go ahead.
I just pulled up yesterday because I was just looking at, what they suggest. And so you just kind of go with the trial fit, and then you just call the consultant and tell them what you see. They kind of walk you through it. And then over time, as you do more and more, you start to kind of pick up on kind of things as you fit the lenses more. And they're willing to teach you, like they actually like to sit down and talk if they have time, and they'll actually come to your office and help you fit some patients if you have a few lined up. So I don't think anyone should be scared to just start trying it. I mean, the worst thing you could do is just, it doesn't work for you, but the best outcome is that you really help the patient who might not have
Yeah.
another doctor to go to.
Yeah, so it sounds like kind of just getting your feet wet, really just jumping in and seeing how it goes is a good way just to kind of get started and then build from there. But you had mentioned before that you did a residency in ocular disease, of course, and it gave you a great foundation for what you're doing now. But I mean, is there such thing as specialty remorse, so to speak? Maybe like you start doing these things, then you figure out, man, I've invested a lot of time, energy, and resources into this, and I'm realizing I don't, it's just not for me, or I don't want to do this. I mean, did you feel that way for ocular disease? I mean, is there a reason why you didn't decide to kind of pursue a very disease-based sort of career, so to speak?
I mean, I still love disease, and I think it's one of the most interesting parts about our field. I really wanted to build a strong foundation for treating patients and not have to refer out all the time. And I also wanted to do it in a VA hospital setting, because that's really one of the best ways to potentially get a job in the future is if you do a residency at a VA, to work at a VA. So really for me at that point in my life, I wanted to build that oct disease foundation, because like I felt that's kind of from there you can build your specialties. And I didn't know that I wanted to do a specialty at that point either. So I kind of wanted to stay a little bit more general.
Mm-hmm. Yeah, do you think that there are any cons to like specializing? I know that might sound crazy, but maybe it doesn't necessarily apply to you per se, but for example, if you are, if you're really heavily specialized into, let's just use you for an example, right? Myopia control, specialty lenses, that kind of thing, and you don't really do much else. Not that that's what you do, but do you feel like that could be a potential, downside to things, that kind of like you forget about some of those other things, those other skills? I mean, I'm not sure that is the case for many, but thoughts on that?
Yeah, definitely. I still like to switch things up. I probably wouldn't want to do myopia control all the time, 24/7. Maybe, build it as my main specialty. But I mean, I love seeing disease. I'm not a big vision therapy person. I think that's a very niche level
Uh-huh.
kind of specialty. But I like doing contacts. I like seeing kind of just sometimes you just want like a general easy patient too. So
Right.
yeah,
The two diopter myope, right?
just
In
sometimes
and out.
need a
Yeah.
break for a second.
Yeah. Always
So
feels good. Yeah. That's how you kind of catch up during
yeah,
the day, Yeah.
exactly. Yeah, and like it's a very it's time consuming with the specialties because they expect a certain level of commitment from you, and they take more of your energy. You have to call the labs constantly, be on the phone with them. So
Hmm.
it's definitely something can get tiring to do just that all the time.
Yeah, and a couple questions came in here on that subject of, lenses and labs and taking the time. So I'll kind of throw them your way and
Okay.
get your thoughts here. And for those that are obviously watching along in YouTube, you can type in the chat. We'll take your questions. Happy to try to answer them the best we can. Obviously, if you're following along on Covalent Careers in the live stream in the education lobby, just jump over. There's a button that will take you right to the YouTube stream that you can kind of type a chat question in, and we'll grab your questions that way. But so questions here, and it looks like some, the community here is actually helping out here, right? So first question was regarding myopia control. I
Mhm.
am certified to use my sight lenses in Canada. Are they available in the USA? So it looks like someone says they are. I don't know if you have any experience with those lenses or not, Laura, but of these lenses, any kind of idea on them?
Yeah, I know of them. I didn't know they were available yet, and I just recently changed jobs, so we're still kind of building the materials that I need. Natural view is a big one. That's the daily lens, and then sometimes I'll just use like bioaffinity monthly.
Hmm.
I know my site's similar, but from what I've heard so far, they're mainly in like Canada and the UK, so I haven't had much experience with them.
Hmm. Awesome. Well, thank you, Krista, for helping us along with the question. We appreciate your response as well. So, a couple other questions here for you, Laura. I've got okay, so two, and maybe these go hand in hand. But one question is which scleral lenses do you personally use, and how do you go about choosing which lab to work with?
Um, well, the lab kind of goes with the company of the lens. I like Zen Lens. They haven't failed me yet. I think that they are great design, and you can change like each specific parameter without affecting the rest of the lens. And the consultants are just really intelligent and they're really helpful. So that's kind of like my go-to scleral lens, and I think it's a lot of people's go-to lens. And then I also did a Valley Contacts
Hmm.
lens, which is a newer company. I'm sure you heard them on like the podcast. There's a podcast called Blink, and or Try Not to Blink, I think it's called.
Yeah.
Yeah, and they sponsor them and work with them, and so they're a great lens too. They're like a younger company, and I chose them because are the only company that does specialty tints on sclerals, because I had a really unique case where I needed to have a tinted lens. So I did get on board with them as well.
Hmm. Yeah, thanks for weighing in there. And a couple other questions popping in. It sounds like this is a really popular topic. And before we answer that question, I mean, I can kind of share my experience too. It was funny because I did an externship in specialty contact lenses. I loved it. It was probably my favorite internship I did while I was in school. Learned so much, and just kind of learned a ton about lenses. And I remember even like designing every single parameter of the lens and sending it to the lab, and then they'd come back, we'd test it out, I'd like take it and I'd do the modifications, and I'd do all this stuff, and it was awesome. And then when I got into practice, it was super interesting because it was like, well, I didn't have all those tools available to me, and I didn't have all these different lens sets, but what I did have was, I
Yeah.
had my slit lamp, I had my keratometer, I had a I don't even think I had a topographer off the top of my head back when I really got into this stuff. And, I called the lab and they were like, okay, give me the refraction, give me the Ks. What is
Yeah.
this, and they really help you. I mean, they are knowledgeable people. And,
Mhm.
9 out of 10 times I would get a lens that needed maybe one modification.
Yeah.
And it was, we were rolling. So kind of going back to what we were talking about before, just because you don't, maybe have all of the experience in the world doesn't mean that you can't get started with a specific specialty. It doesn't mean that you need, special equipment, so to speak. But we will talk about that coming up in a second. But
Yeah.
before we run there, let's answer some of these questions. So, question here is, do you have a go-to lens for patients with both dry eye and astigmatism? So I'm not sure if that is maybe soft lens or maybe you are using rigid lenses for patients like this, Laura. I mean, any thoughts?
Yeah. Well, scleral lenses are great for dry eyes. They're a very therapeutic lens because they have the saline that sits on your eye the whole time. If you're looking for more of like a less specialty lens, I actually have a pretty high astigmatism in one of my eyes, and I've had dry eye in the past. So there's a great new daily lens, the AccuView Oasis Hydroclear One Day for astigmatism has been really popular. And then there's Dailies Aqua Comfort Plus, which is pretty good. But also, I think you can stick with a monthly. Like I wear Biofinity at monthly as well, and just kind of taking good care of the lens, like using a clear care hydrogen peroxide based, using artificial tears, like that could make a world of difference.
Yeah, for sure. Thanks for sharing your thoughts. We'll keep an eye in for an eye. I'll keep an eye out for any more questions that pop in. But I wanted to go back to kind of what I was talking about before, just moments ago, and equipment, right? So a lot of people say, man, I'm interested in doing specialty stuff, but I don't have equipment, or what kind of equipment do I need? So I guess in terms of specialty lenses, I know, I briefly touched on it, but I'd love to hear what your thoughts are. But particularly myopia control. I mean, how, because you're doing a lot of that now. So like, how did you get started? Do you need special equipment, and if you do, what do you need?
Um, Not really. You really do need a topographer for like orthokeratology. You don't need it if you're doing myopia control, such as like the soft contact lenses or the atropine. What was really nice about my old office, because I was in ophthalmology office, we had the ability to measure like the axial length. So if you're really into it, it kind of is like a nice additive to show the patient that the eye is actually staying stable, especially some patients who are more scientific. But if you don't have that, it's okay. You can still, it's nice to have an autorefractor so you can get Ks and kind of keep an eye on the refraction. You need a slit lamp, and basically you just need the lens, which is, I use Paragon CRT, which is probably the most popular uh,
Hmm.
company to use. And yeah, I would say that's pretty much it. You don't really need that much.
So kind of a low barrier to entry is what it sounds like, which is good. I mean, if you're trying to get started, how do you start to build that patient base though? Because, like you said, you're just getting started, which probably means your practice is getting started. I mean, maybe unless you're joining a practice that already does these things, you're kind of just jumping in and, doing it. But if you're kind of building this from scratch, right, you kind of need to start to advertise this stuff. So how do you advertise these services to not only maybe existing patients, but patients that aren't currently in your practice? How do you build that patient base?
Yeah, so a great way you can do it is you can have like a survey and tell the staff to kind of give it to any patients who have kids like at a certain age, and then they can fill it out and bring it to you. And then if they qualify, you can discuss it with them. Um, any kind of advertisement in the waiting room is a great way to kind of, because a lot of patients come and go, hey, I saw this. What is this about? Can I do this? If you want to be a little bit more aggressive, I actually, at my last job, I was able to contact the local news station, and they actually came in and did like a short segment on what I was doing, which was really great exposure for the practice. So I was a little bit more persistent. And then lastly, kind of reaching out to the schools and the pediatricians is a great way. So I would give my business card and kind of give them a flyer about what I do, and kind of building that relationship.
Hmm. Yeah, great tips. I know that a question that often comes up, and I know that we might not be able to necessarily say, this is exactly what I charge, and here's, what I charge, because, there's always the concern about collusion and all that stuff. But
Yeah.
just general ballpark, I mean, how do you decide, or how do you understand, or what resources are there for you to kind of figure out, this is what I need to be charging for these services? So, maybe specialty contacts, I guess there's some different things involved there, right? Like materials, that's, one thing, but
Yeah.
just kind of your time, right? So let's start there, because I think myopia control is a whole nother topic in and of itself, in terms of trying to understand, or figure out how to charge for your time and that kind of thing. So any tips on that?
Yeah, so I usually calculate kind of like how much chair time and how much like that time would be to me. We usually double the cost of the lens, so we are able to make a profit that way. And also you have to think about time that you're spending talking to the lab, designing it. I definitely learned it's more time consuming than I thought initially. So I started a little bit on the lower end because I was new and kind of experimenting and getting better at it. But then at a certain point, you realize how much chair time you put in. And we do like to bundle it. So we don't want to kind of spring any more money later on the patient. So it's better to kind of maybe charge a little bit more and just cover for something that may potentially happen, than kind of undercharge and say, you know what, we need to like add another charge because we have to pay for this new lens.
Mm-hmm. Yeah. And what about like with myopia control? Because I guess that's a different kind of thing. Well, maybe it's similar, but it could be different in the sense that like, you know, what does that follow-up schedule look like? How many times are they coming in? Because that's more of like a long-term sort of a process, right? I mean, a specialty lens, sure, you have them in your chair, you got to order lenses, you got to have them back, you got to look at the fit, maybe you have them back again to look just to check again one more time. But with myopia control, it could be something like, hey, we're gonna do this, come in, okay, we got to do this, okay, come in like a month, we got to check progression. 3 months, 6 months, how are you trying to figure out like, this is what I got to be charging because this person could be coming in 6 times in 1 year.
Yeah, that's actually usually the case. So I think with all the specialties, usually it's like we do a week and then a couple weeks and then a month, 3 months, and then 6 months. There's really no point in doing any like eye measurements until 6 months out because the eye just doesn't grow that fast. It's such a small unit of measurement.
Hmm.
But definitely you want to be cautious, make sure there's no side effects with the drops. With Ortho-K, it's kind of like fitting a scleral. Like you have to make sure the fit's good. And if not, then you have to reorder the lens and then you got to give them another week or two to adjust to it. And then you got to take a lot of measurements like, over refraction, how they're seeing with and without the lens, topographer. So that's Ortho-K is probably the most time consuming, but what I like about it is not only does it slow nearsightedness, but it also allows kids, especially in sports, to not have to worry about contacts or glasses during the day. And parents really like that idea. So it is about 6 visits the first year, and then it goes to about like twice a year.
Got it. Yeah, we've got a couple other questions that have come in, and one looks like so it looks like three maybe here. So let's start with this one because it kind of piggybacks off of the whole discussion around costs. But what is your cost for myopia control for atropine therapy? So maybe not specifically what do you charge, but how do you go about understanding your what to charge a patient there if you're using atropine therapy versus maybe scleral or not scleral CRT therapy?
Yeah. Well, atropine is a little bit less, I have to admit, but we don't like to make it too different because we don't want people to feel like one treatment is better than the other. They all pretty much include similar like time frames for visits. For the atropine, we have the patient pay for their own drop because insurance varies. So we have them pay for that, so that's not included. We also like to include a pair of glasses like a progressive lens to help like reduce their accommodation up close because atropine can cause a little bit. I haven't found it to be too bad with the low amount, but just a little bit of accommodation issues up close. So
Yeah.
we include that in the pricing and for all of them. And then just kind of like our time and knowledge, like my knowledge of the drop, working with it, doing research on it. I know a lot of the background mechanism for atropine. So I think that's valuable in itself.
Yeah. And another question that came in too on the topic of your, atropine dosage and stuff is what dose of atropine do you prefer to use? What is your preference?
I like to start with the 0.01%, but I'm not afraid to work my way up if I need to. I mean, the studies have shown that the higher amount, obviously, you get the bigger effect, but then there's also a bigger rebound effect, and there's more side effects. So, you want to kind of see it almost slow to about 0.25 a year is okay. I'd like really like to see no change. That would be ideal, but that's hard to get when the kid is still growing. Um, yeah, so I would say that I start on the lower end, and then you can also combine therapies. So you can do soft multifocals with atropine if you're not finding enough. But I would be weary about probably going over like 0.25. I haven't really gone up to that, but I've seen
Mhm.
studies that have.
Gotcha. A couple more questions coming in for you here. Everyone's super interested in myopia control, and
Yeah.
so this is good. I'm happy, happy to see the questions coming in. So,
Okay.
what ages do you start and stop recommending myopia control lenses? And so I guess that's one question technically.
Okay.
So, what age do you start and stop recommending myopia control lenses? I've got a follow-up question. Well, let me just ask it now. And, have you found that parents are receptive to the idea of this?
Yeah, I found sorry for the first question. I like to do between the ages of 6 to 13. I find after 13 it's not as effective. There's a nice graph online. I think it's under the Brian uh, Brian
And,
Holden Institute,
mm-hmm.
where it shows you like what age and what type of treatment you use, where they would be in like 5 years. So, but if the kid is 5 and able to handle, doing the myopia control with the parents' help, that's even better. Like the sooner the better. But 6, they're usually responsible enough to do it on their own a little bit.
Got it. And, in terms of parents being receptive to this, I guess it kind of all ties into education, right?
Yeah,
And marketing, right? I'm sure that kind of plays a big role.
yeah.
The other questions, some other questions that came in regarding myopia control, and I don't know, Laura, you'll have to tell me if you've got experience using bioaffinity multifocal distance lenses.
Mhm.
So the question is I've heard that the highest ad is recommended to start with. What should patients' vision be? How do you check VA, monocularly or binocularly?
So I check both, but I'm kind of a little bit more lenient. So I'm like 20/20 happy. So if they can function and play their sports and they're 20/25, but I can get them in a plus 250 ad, I'd rather do that. Sometimes I do have to over minus them a little bit to be able to function in school. So I'll do a distance center near periphery type lens in both eyes. And I found that sometimes I have to over minus just by 0.25, but other than that, they don't really have any issues like accommodating.
Great, great. Yeah. And a follow-up question is what should distance VA be with the multifocal lens? So it sounds like you do shoot for that 20/20, or at
Yeah,
least close to it.
5. Yeah.
Yeah, yeah. And the experience that I've had doing this too, I've used this lens before as well. I found that when I first did it, I think kind of similar to what you were saying, I had a VA of like 20/25 and it seemed to be okay in the office, but then I got a call later on like, yeah, he's just having a hard time, functioning and seeing the board. So we got him back in and I did have to over minus a little bit to get him to that 20/20 happy, but
Yeah.
so that's kind of, just sharing my own personal experience. Someone has another question here for you. And, going back to atropine, how did you find a compounding pharmacy that you use?
Um, so my last job, there was one called Pine Pharmacy. I think they're located in the Midwest in Michigan. So I literally just called them up. They're used to
Yeah.
people.
And what was the name of that for those that might have not heard?
Pine Pharmacy.
Pine, like Pine.
Yeah.
Awesome.
Other than that, you can, if you want something more local, usually you can just ask around or ask like your local pharmacist if they know any compounding agencies, and usually they can help you with that.
Hmm.
I haven't done it yet because I've only been at my job for a couple of weeks, but I know we have someone in the area, I think, who does it.
Awesome, awesome. And then what does your dosage schedule look like is the question that came in here. How often is the patient using the atropine drop?
I like every day if
Hmm.
possible. Yeah.
Great, great. So happy to take any other questions that come in, in the minute or so that we really have left. But otherwise, certainly, Laura, if people do have other questions for you and they want to get a hold of you, what's the best way?
Probably through email. I don't know if you want me to, give it to you, and then you
Yeah,
can.
we could add in the description here. What is it? The email that I talked to you, I kind of correspond
That's
with?
the best one until I get my work email set up. And then,
Fantastic. Great. Well, thanks for joining us, Laura. It's always a pleasure. And thanks, for the people who are following along live with us. Thank you for so many questions and asking and participating. We appreciate it. And a lot of the folks, I don't know, Laura, if you can see the live kind of chat going on the side or not, but everyone is saying thanks. So
Okay,
you've
you're
you've
welcome.
helped out a lot of people. So that's our goal here. So thank you to everybody involved. If you're watching along and following along with us throughout the day. We're going to be staying in the education lobby, talking about rookie mistakes next. So stay tuned for that. We'll be starting that one shortly, close to on the hour. And for those of you following along on YouTube, you can catch us on the next stream, of course. Subscribe. We've got a lot of other great videos and content. So thanks for tuning in, Laura. Thank you for your time. And we will talk to everybody here shortly.
All right. Thank you so much. Talk
Yep.
to you.
Take care.